Excuse me. So this lecture is going to look at some of the current treatment options that exist for MS. Learning objectives. And so the treatment is dictated at the progressive stage of MS is typically a little bit more difficult than treatment for other forms of MS, such as the relapsing forms. There's a number of effective disease-modifying therapies that are available. In contrast, ocrelizumab, which is pretty much the only disease-modifying treatment option with really high-quality evidence of efficacy for patients with primary progressive MS, or sometimes called PPMS. Therapeutic options for these patients with secondary progressive MS are even more limited. Cladribine, which is given often IV or subcutaneously, is an antimetabolite, and it doesn't really appear to favorably alter the course of the disease, either in terms of the attack rate or the disease progression. It is possible that metoxantrone has a beneficial effect on disease progression in MS, but the drug is seldom used because of its pretty dramatic toxicity profile. Methotrexate is an immunomodulator, which showed no statistically significant difference in symptomatic improvement or radiology findings in several patients. So really, we're looking at immunosuppression type drugs, and the main one is ocrelizumab, and this is a recombinant CD20 monoclonal antibody. And this is really the first drug to significantly reduce the risk of disability among these patients with primary progressive MS. The drug is typically given under medical supervision because it's got severe infusion reactions. Of course, it's given infusion only. Pre-medication is recommended with both methylprednisone as well as an antihistamine, such as diphenhydramine or Benadryl. To reduce the frequency and the severity of infusion reactions, an antipyretic, such as acetaminophen or ibuprofen, is usually given as well. Both azathioprine and cladribine have also been investigated as medications to kind of help with these relapsing, remitting, and chronic progressive forms of MS. Other drugs exist for the treatment of progressive MS, and we're just going to highlight a couple of them. Glucocorticoids, our old friends, of course. These are immunosuppression agents of pro-inflammatory genes. In this context, they're more often given IV. There's been limited clinical data showing effectiveness of these drugs. They're used primarily for the treatment of PPMS or secondary progressive MS, either alone or in combination with other immunomodulatory or immunosuppressive type medications. Cyclophosphamide is actually an anti-cancer type drug. It's specifically an alkylating agent with a long history since the 1940s. It's been used in MS treatment since probably early 1980s, but the data has been really inconsistent. However, it's still used because there's not that many drugs out there. Typically, nausea and vomiting can be managed with antiemetics. Infection, however, should be treated promptly with the appropriate antibiotics. Cyclophosphamide is nasty. It is a chemotherapeutic. It's also teratogenic, and it can't be used in pregnant or expecting women. Likewise, metoxantrone is effective for patients with worsening relapsing remitting MS or secondary MS. However, the risk of cardiotoxicity and the potential for the development of leukemia with this drug really limits its use. This drug is more often typically reserved for patients that have a really rapidly advancing disease and who have failed pretty much everything else. It's the cardiotoxicity that is really kind of dose limiting, and it increases with the cumulative dosing of this drug. There are treatments for remitting MS, and they can be subcategorized based on whether or not they're injected, they're infused via an IV, or if they're given orally. And so there's a handful of drugs in each category, and this is just one of the ways in which you can classify these drugs. The immunomodulatory agents are considered disease-modifying therapies because they really reduce the relapse rate, and they actually slow the accumulation of brain lesions upon MRI imaging. The earlier in the evolution of the disease, the greater the likelihood that the disease progression will be slowed. There are up to date 15 disease-modifying drugs that are used for MS, and they can be subcategorized into drugs that are injected, infused via IV, or orally administered. Just to summarize the injectable treatments, we're really kind of looking at interferon 1 alpha and interferon 1 beta combination, which is under the generic name glatiramer. If you look in the literature, there's, especially in the step prep guides, you may see reference to daclizumab. This was recently withdrawn from the market in 2018. March of 2018, due to severe adverse effects, mainly hepatotoxicity, as well as encephalitis. So in terms of the injectable agents, really the only one that's left is the IFN interferon 1 alpha and beta combination. So this drug is for relapsing MS. It's got two mechanisms of action, and really it's going after the T cell infiltration into the blood-brain barrier, as well as the T cell activation. Flu-like symptoms are pretty common with this drug, and that can be treated with one of your COX inhibitors, or glucocorticoids, or Tylenol, acetaminophen. There's a high prevalence of asymptomatic liver dysfunction that's associated with this therapy, and there's 3 formulations, and you don't need to know what are the differences between these formulations, but just know that there are several formulations that exist, and there's a 2-part mechanism of action there. There are amino acid decoy molecules. Glatiramer is also known as a decoy molecule. And glatiramer is really a mixture of random polymers of up to 4 amino acids. The mixture is basically antigenically very similar to myelin, basic protein, and a component of the myelin sheath of nerves. And so this immunomodulatory mechanism of action of glatiramer basically involves the binding to MHC molecules and the consequent competition of various myelin antigens for the presentation to T cells. So in addition, glatiramer is also a potent inducer of specific T cell helper type 2 responses, and these express anti-inflammatory cytokines through a regulatory or suppressor mechanism. Side effects of glatiramer include local injection site reactions, and less commonly transient systemic post-injection reactions such as chest pain, flushing, palpitations, or anxiety. The infusion agents are basically monoclonal antibodies. We've already talked about ocrelizumab. This is a CD20 targeting molecule. We've already talked about metaxalone, which is basically a chemotherapeutic molecule. Let's talk about alemtuzumab. Alemtuzumab binds to CD52, which is expressed on T cells. Viral infections, autoimmune disorders, and so forth are the main side effects. In the US, treatment with alemtuzumab requires a special registration through a restricted distribution program. So you can't just write a prescription for this drug for anyone. There has to be some type of criteria. This drug was approved in 2014, and it needs, as I said, meticulous monitoring, as that side effect profile is quite long. Natalizumab is another monoclonal antibody. This one's an adhesion molecule that basically inhibits leukocyte adhesion and migration. It goes after the alpha-4 beta-1 integrin specifically. And it's a highly effective drug for the treatment of relapsing remitting MS. Activated effector memory T cells and monocytes that travel through the intracranial circulation have the ability to extravasate within the MS lesions and cross the blood-brain barrier. These cells mediate pathologic inflammation in MS. All these cell types express alpha-4 beta-1 integrins and then basically allow these cells to be transported through the CSF. Natalizumab, which is a recombinant humanized antibody, binds to and inactivates this integrin molecule that I just mentioned. As a result, leukocyte migration is severely restricted, as well as a reduction in inflammation and the prevention of lesions. I do want to point out that there is a black box warning for this drug because there's a well-documented and associated risk of progressive multifocal leukoencephalopathy, which was described in much more detail by Dr. Richards in another presentation. This is an opportunistic viral infection of the brain, and it leads to severe death and disability. So we will end this particular presentation right here, and we'll continue for the other half of this presentation in the next slide.